Johannes, you look very serious.
What's that?
You look very serious.
Oh, really? You too. Yeah.
Oh my God, I look very sleepy, probably.
Yeah. Where are you now?
Cleveland. I'm in an hotel. I'm
Yeah.
looking for
At
a
the
house.
Intercontinental.
It's a continent.
Yeah. Cheers. Yeah.
The usual place. We have all been there.
Yeah. No, but it's good. When do you start?
June 15.
15. Very good.
Yeah. And I take May off. I go to Europe for a month. So looking forward to it.
Yes, sure.
Alive? Můžeme začít? Začínám. Okay, good morning, everyone. Welcome here in Prague. We are today broadcasting this expert panel with the title "Advancing the Frontiers of Robotic Cardiac Surgery." My name is Stepan Cerny. I'm a cardiac surgeon. I've been in robotics since 2007, and I also have been part of the reintroduction of the robotic cardiac surgery in Europe in the past years. This webinar is a part of the first Prague Robotics Summit, which was taking place here in Prague yesterday and day before yesterday. For the today's panel, we have an excellent panel here in Prague. The session will be co-moderated by Dr. Hristo Kirov from Jena University Hospital. Welcome in Prague, and we have some other panelists online. Just let me introduce them. It's my great pleasure to welcome Johannes Bonatti from the University of Pittsburgh Medical Center, one of the pioneers of robotic cardiac surgery. Welcome, Johannes.
Hello.
Other panelists, Gianluca Torregrossa from Lankenau Heart Institute, who is now moving to Cleveland Clinic to establish an expert coronary surgery, robotic coronary surgery center. Gianluca is one of the rising stars of the robotic cardiac surgery of today's. Online is with us also Professor Jan Vojacek from University Hospital Hradec Králové. Jan is also an excellent robotic surgeon. He established one of the biggest European robotic centers doing both intracardiac and coronary work, but the center is mainly concentrated on coronaries, and he's publishing, or we will soon publish, even a prospective randomized trial, open MIDCAB, against robotically assisted MIDCAB. Welcome, Jan. Later today, we will be joined by Wouter Oosterlinck from University Hospital Leuven. Will join us with a talk. As I said before, we had a first or inaugural Prague Robotic Summit. Hristo was also part of it. So yes. What was your impression?
Well, first of all, it's a pleasure for me to be able to take part in the first Robotics Summit. And if I can paraphrase a famous football song, it's not football coming home, it's the robots coming home. Because I don't know if you know, I learned it 2 days ago, but the word robot is originating from Czech, here from Prague, from a 1921 play of a famous science fiction Czech author, Čapek. And I think it's symbolic that the first Robotics Summit is taking place exactly in Prague. About the summit, it has been a great pleasure to see Stepan Cerny perform. I think he's the first surgeon who performed in one day a brilliant robotic Barlow repair, and immediately after that, afterwards, robotic TECAB. There were a number of presentations, how to do it, vivid discussions, and yesterday we finished with a congenital case, so we had the full spectrum, almost the full spectrum that robotic surgery, cardiac surgery can cover, and I can only hope that this first summit starts a good tradition.
Thanks. Thanks, Hristo. So the format of today's webinar will be that we will start with the rapid-fire presentations of all panelists, and then we will discuss all the aspects of robotic cardiac surgery. The first presentation will be robotic cardiac surgery platform for the future. Then we will discuss TAVI against the robotic AVR, and then there will be a block about coronary revascularization, because as you know, we have different techniques how to approach the robotic revascularization, and then later on we will be joined by Wouter Oosterlinck, who will talk about AI in robotics in cardiac surgery. So it's probably time to start, and I will start with the first presentation. I just would like to give you a short overview of the current situation of robotic cardiac surgery and how we see it today. We see it as a platform for the future. So as you all probably know, the first robotic cardiac cases were done in Europe in '98. Between '98 and 2005, the major steps were done with most of the techniques and surgeries performed. This is the overall numbers of robotic procedures in the world. You see very slow adoption of the technique, but then there was a stagnation between 2008 and 2015. Then the fourth generation of the device was reintroduced, which led to some renewed interest, but the major increase of the numbers is after the year 2020, after the COVID. It's an explosion of the robotic cardiac procedures around the globe. In Europe, the number of robotic centers is growing. It doubled between 2016 and 2019, and it's growing after 2020 and will grow in the next years. Currently, we have two applications, revascularization and intracardiac robotics. The revascularization can be either robotically assisted or performed. The key part is, of course, the IMA harvest with the robotic instruments inserted in the left chest, and then either with a subcostal stabilization or a limited thoracotomy, you can do a full robotic revascularization or robotically assisted MIDCAB. That's the difference from outside, but from inside, the result of the operation is the same. So two IMAs to the left main territory. Intracardiac robotics, probably the mostly standardized technique is the robotic mitral valve repair. Thousands of procedures done every year all around the world. Very standardized, second, third, fifth intercostal space, left atrial retractor, some assistant port, traction sutures. And the beauty of robotics is that you can access the mitral valve with 3D camera, LA dynamic retractor, and one or two assistant instruments. All the techniques can be done with robotic mitral valve repair. You don't need to change your technique of the valve repair, leaflets repair. You can do triangle resection, artificial chordae with any of the techniques, or a complex reconstruction. Another beauty of the right lateral approach is that you have a very good approach to both AV valves to the aortic root, and if you cross-clamp the aorta a little bit higher, you can open the aorta and easily replace the aortic valve. And again, the same scheme working at the aortic valve with 2 robotic instruments and 1 or 2 assistant instruments. Very similar setup, just bigger assistant port for inserting the valve. We will definitely discuss it if we can limit the incision or not. The beauty of the robot for AVR is especially at the level of the aortic annulus, placing the surgical sutures with the articulated instruments with the ability to work at 7 degrees of freedom, and you can replace the valve with classical surgical technique and fix it with a Cornuds. You can expand your work to double valve surgery. Some other surgeries like LVAD implantation was done, and as you probably know, even the heart transplantation was performed robotically through 6 centimeter thoracotomy. The diseased heart is removed, the new heart is inserted in the chest and implanted with classical bicaval technique. So where do we stand at the moment? The expert centers are currently doing a mix of procedures, probably half of intracardiac, half of revascularization. It depends on the orientation or specialization of the center. In Europe, between 16 and 20 was half of the revascularization, half of the intracardiac work. Now the revascularization is growing. In the future, we will be definitely shifting the paradigm in robotic heart surgery, moving from single procedure approach to establishing a robotic heart center of excellence. So how will the robotic heart center of excellence look? It will cover the whole spectrum of cardiac surgical procedures, probably mainly concentrated around the valve surgery, mitral valve repair, and a full spectrum of surgical revascularization. So let me conclude. What is the robotic cardiac surgery today? Robotic cardiac surgery is not a single operation anymore. It's a platform for all of cardiac surgery. Thank you. So that's my view, how it looks today and how it will look in the future. And we will move to the second talk to be given by Jan Vojacek from Hradec. And he will expand a little bit more on one of the intracardiac applications, TAVI versus surgical and robotic AVR in younger patients, key consideration, and I hope we will also hear about the opportunities for robotic cardiac surgery in this field. Jan?
Thank you, Stepan. Thank you for this nice introduction. Good morning, everyone. Let me just try to upload my slides. Yes, can you see my slides?
We can't see them here, but we can see them on the screen here in the room. So.
Great. So, good morning, everyone again. My name is Jan Vojacek, and I'm cardiac surgeon from University Hospital Hradec Králové, and one of my expertise is also robotic cardiac surgery. Let me also thank all of you for organizing such a great event, namely Peter Surgical, Lorette and Statis, and everything is done under the leadership of Stepan Cerny and Gianluca Torregrossa. I had the chance to, participate on the first day of the course with 2 live procedures, and it was really a great experience, nicely organized. So thank you again. Now, my topic is TAVR, transcatheter aortic valve replacement versus surgical and robotic AVR in younger patients, key consideration. And As you know, new European valvular guidelines, which was published just quite recently at the end of the last year, recommended age limit for TAVR in 70 years. So actually they lowered the age by 5 years, and I believe without having sufficient evidence. So we should choose the valve substitute and optimal procedures, I believe, from the perspective of so-called lifetime management. Because different age means different preferences and different lifestyle. Now, the question is who is old and who is young? It's just a number. And we should consider more on biological age of the patients rather than on calendar age. If you look at this slide, you see that if somebody is 70 years old, we used to call these patients as elderly patients. But you have to realize that these patients have, long life expectancy. Like in men, they are going to live 13 years, and women, they live even longer, 16 years. So they have, a lot of years to live. And that's why, and this is our main task for us as a surgeon, to choose a valve substitute and procedure to restore survival and to restore quality of life. Now, we all agree that TAVR is a perfect choice for the patients with symptomatic severe aortic stenosis in high-risk patients or inoperable severe aortic stenosis, and also in patients in intermediate risk. As it was proved by many prospective control randomized trial. So there is no argue that it's play major role, and it's a great news for the patients that we have such a tool. But if you look at the intermediate results, and these are 2 years results from the perspective of freedom from death, from any cause or disabling stroke, you can see that immediate and early results are always in favor of TAVR because it's a less invasive procedure. But if you look, and this is again a partner 2 trial, so in intermediate risk patients, if the follow-up is longer, so you can see that this survival curves are going to cross a certain point, usually during the 3 years. Can you hear me? There is some noise. Can you hear me?
It's okay now. It's okay.
Okay. It's okay. So these curves are going to cross at 3 years, and they are going to diverge. So this is only 5 years results of partner 2 trial in intermediate low-risk patients. Do we have a longer follow-up? Yes, we have, because last year 10 years partner 2 data has been released, and they were just posted on FDA website. But unfortunately, those data, they have never been published, and they have never been presented in any conference, which is a pity. But we as a surgeon, we did our analysis, and those data are clearly in favor of SAVR comparing TAVR. So if you look at these data from the perspective of long-term results, surgical AVR has better result. Now we have also randomized trials in low-risk patients, and these are the results of partner 3 trials, where patients were randomly assigned to SAVR or balloon expandable TAVR valve. And as you can see, this is exactly the same. Immediate results are in favor of TAVR, but survival curves are crossing at 3 years, and they are continued to diverge. Unfortunately, this difference, which is in favor of surgery, was not statistically significant, but it tells us some message that maybe during the 10 years, these results will be significant. We also have currently new data regarding Evolute low-risk trial, which and these data were published in JAC 2026. This paper is just in press. And as you can see, it's a comparison basically of self-expandable valve and surgery. And you can see that again, during the 7 years, those data actually favoring surgery comparing to TAVR, but again, those results are not statistically significant yet. But what is significant is rate of reintervention, because rate of reintervention was significantly higher in patients having TAVR comparing surgery, both at 6 or 7 years, which is important message, especially if we know that during starting 2019, when FDA actually approved implantation of TAVR valve in a low-risk population of the patients, there is tremendous increase of TAVI explants. And this procedure is high-risk procedure comparing, for instance, reoperation after SAVR. You can see the risk of stroke is almost 5% and the risk of mortality is 15%. So it means that from a perspective of lifetime management, these patients would benefit more if they would have SAVR performed first as an initial procedure and then following, for instance, with SAVR or with TAVR. Also, this is another very interesting paper, which is now, which has been published quite recently in the New Journal of Medicine, New England Journal of Medicine in 2026, and it's actually a randomized controlled trial comparing asymptomatic patients with severe aortic stenosis, and these are, conservative treatment and early surgery. Early surgery meaning these are asymptomatic patients who are not fulfilled criteria for surgical AVR according to current guidelines. And you can see there is a clear survival benefit of early surgery comparing conservative treatment, which is, very statistically significant. Now, as Stepan Cerny said, there is actually a new option how to address aortic valve, which is robotically assisted AVR. This is the actually video of the patients who were who was indicated for mitral valve repair. But you can see that using the same approach like for mitral valve repair, you have a great exposure of ascending aorta, aortic root and aortic valve. So all you have to do is to put the cross clamp, make incision and implant the valve. And really, there are some initial data about it. Vinny Badvar is actually the one who established this kind of procedure, and he published first 50 cases with very favorable results. And there is another paper coming also from Vinny Badvar, and it's initial multi-center experience with robotic AVR, compromising more than 200 patients from different departments over the globe. And as you see, our University Hospital and also University Hospital Motor participated on this study. There was this kind of duration of CPB and cross-clamping time. The duration is, of course, longer. And in 71% of the patients, biological AVR was implanted. What is important that there was a lot of concomitant procedures, including aortic root enlargement, LAO, biatrial cryomaze, myectomy, and also mitral valve repair or mitral valve replacement. And the results were very good. You can see that there was a low risk of morbidity, and the risk of in-hospital mortality was just less than 1%. So we, as a group of robotic surgeons who are interested in robotic AVR, we established this robotic task force on WhatsApp platform, and we are sharing our experience. As you see, Johannes Bonatti performed first robotic AVR on Cadaver Lab, the first case of AVR at MGH, New England. This is from our center. Finally, we made it. First robotic AVR in Czech Republic and center part of Europe, and so on. So we are constantly and continuously sharing our experience, which is very good for development of such procedure. Let me also show you a short pre-recorded video of robotic AVR from our center. You can see that exposure is very good. This was a very good candidate because there were just limited calcification. This patient suffered from pure aortic insufficiency, so it was easy to excise relatively pliable aortic cusp. In patients, especially with bicuspid aortic valve, there are always heavy calcifications, which is probably the most tricky part of this procedure because we don't have dedicated instruments to debride aortic annulus from calcium. But once you do it, then putting the sutures in a standard fashion is relatively easy. What is not easy is then to put those stitches into the prosthesis properly, not to get lost. But again, once the valve is in, we make the knots using core knots, of course. And again, you can see that exposure of the valve is really nice. And closure of aortotomy into layers. And final cosmetic effect, which is brilliant. So let me conclude. Mini-invasive valve surgery generally is definitely way to go. It's must if we want to compete with TAVR. This is the way to go. Otherwise, we will not get enough patients for our program. There are different platforms for minimally invasive aortic surgery, like partial sternotomy, right anterior thoracotomy, very interesting transaxillary approach, and of course now even robotic AVR, which is the only fully endoscopic approach comparing previous minimally invasive technique. But there is still a long way to go. But I believe it's kind of a window of opportunity for robotic aortic valve replacement. This procedure enables in dedicated centers combined robotic procedures or multivalvular procedures, but those procedures must be centralized in dedicated centers, and there is a support for this in current European valvular guidelines, where we have a term of heart valve centers of excellence. So I believe it's one of the options, one of the directions we have to go. There is a big potential for robotic AVR. We need the support of company, and they are aware of it, and they are now supporting us, as we need new tools and new robotic instruments to do this kind of procedure safely. But I believe the future is bright, and we have just to keep on. Thank you for your attention.
Thank you, Jan. A beautiful presentation. I also saw some questions popping up. I would suppose that we go on further with the next presentation, and after that we'll have a discussion, so there would be sufficient time to address all the questions and to discuss. So I'm glad to present the next speaker, who actually does not need any presentation at all, because everybody knows Gianluca Torregrossa, who is presenting on beating heart TECAB, expanding the boundaries, and we're looking forward to your presentation, Gianluca.
Thank you so much, and really thank you, Hristo, for the kind words. And thank you for the organizer to inviting me here. I must admit that I'm here against my wishes. Okay, I wish, number one, to be in Prague with you, with all of you. Number two, it's here in the United States is 4 o'clock in the morning, and it's definitely not favorable for that time. And number three, yesterday Italy lost the qualification to enter the Italian World Cup. And Stepan Cerny sent me the video of the last penalty kick in which Italy. I'm still crying. I couldn't sleep last night. To me, it's a terrible time. I will try, despite the adverse event of my life, to present why TECAB is the present and future, in my opinion, in coronary revascularization. These one are some of the incredible paper published on the left by Dr. Joe Sabic, 1 million patients and the trends of the use of a second arterial conduit in sternotomy coronary artery bypass grafting. We have more evidence that prove the benefit of a second arterial conduit in CABG than evidence to prove mitral valve repair for degenerative mitral valve disease. And yet our rate of adoption of a second arterial conduit is still extremely low and very disappointing. We have almost killed, almost completely, the technique of off-pump surgery via sternotomy CABG, creating almost a forgotten child that is off-pump CABG, an incredible technical procedure that can allow really and improved in terms of stroke and survival for dedicated type of patients. So I think that in the current era of coronary artery bypass grafting, we are still in a very prehistorical way of performing CABG. 90% plus in the United States of CABG patients, 250,000 done every year, are performed via a sternotomy, arrested heart, a big clamp on the aorta, a bunch of cannulas, 1 mammary and 2 veins for all comers. And I think that there are so many more options. We need to advance the community skills of our centers to being able to perform a CABG now 3.0 or 4.0 that makes sense in 2026. And I'm not here to say that everything needs to be done robotically. I do not believe that TECAB is here to take the place of sternotomy CABG, but I do believe that minimally invasive form, robotic-assisted CABG and TECAB are excellent opportunities to integrate together with PCI in an hybrid strategy for selected type of patients. And more patients that currently receiving multivessel PCI should receive a form of hybrid revascularization or 2 mammary artery for the left coronary system and just maximize medical therapy with PKI inhibitor and aggressive management of all of the risk factors. And even the framing of all of our conversations, the scientific background where we live is still stuck in the prehistory, still eternally debating CABG versus PCI. The entire conversation of CABG versus PCI stands like a landline. One time they were very useful, nowadays nobody uses them anymore. We need to advance the scientific background. There is a Netflix series of CABG versus PCI, and we are at season 400. It's time to kill this season and try to kill this series and try to advance the game. The future, the end of this series has been already proven. Reality is that CABG works excellent for subset of patients and offer an incredible adjunct to respect of PCI that is a surgical collateralization. PCI is an excellent procedure, particularly in short defined segment or in an acute coronary syndrome. So instead of a CABG versus PCI, we should imagine that there are a subset of patients that could benefit from CABG plus PCI and in selection. The Robo has this unique opportunity, 3 small incisions on the left side of the system and the ability to have a very high defined magnification to take 1 or 2 mammary arteries. No opening of the chest, no risk of sternal wound infection, maintaining the right internal thoracic artery in proximity with your left. You see the 2 mammary arteries are close to each other, only just few centimeters. And this concept that the Rita never reach its final destination is because we open the chest and we bring always the Rita during sternotomy CABG away from its final target. So MIDCAB has been, and it is still, the most common performed procedure in robotically assisted or in minimally invasive coronary artery bypass grafting. The takedown of 1 or 2 mammary arteries and the deployment of these mammaries via a small thoracotomy, with or without a incision. The cosmetic results can be done and can be very nice, as you see in these cases. So my personal cases of robotic MIDCAB, which is a great operation, has a very solid future, and a lot of individuals out there should take their time to learn how to properly perform. But after around 300 of these robotic MIDCAB, I started to feel the limits of this operation. And the limits is that the reality, despite we maintain a small skin incision, underneath we open the thoracotomy pretty widely. And these patients at the end, they have pain. Thoracotomy is a painful procedure. Number 2, you are trying to advance your game. When you are trying to reach the lateral wall, you start to face some challenges via a thoracotomy. You have to increase the size of this incision to reach the lateral wall, or you have to go on bypass femoral fem to unload the heart and improve your visibility. And generally, patients with coronary artery disease are vasculopath, and so the implication of performing a peripheral cannulation in this type of patients is just different than patients with mitral valve disease that generally don't have a lot of vasculopathy. Finally, patients with large breast or complex chest, the thoracotomy might not be easy. And the reaching of individual target, including the right coronary artery, can be very challenging via a thoracotomy. So if you want to imagine MIDCAB is just a keyhole surgery. You are outside with a light, try to illuminate your final destination. It's just landing your airplane on a helipad. You are basically deploying your Lima to the LED. And when you see the most important series of robotic MIDCAB, at the end, they are always and consistently taking care of one single vessel, that the LED. Is a great target, is a very important target, but there is more than that. And if you want to expand the opportunities, if you want to try to treat more patients, access the left system, again, access the right coronary artery, dock the Robo from the right side and deploy a Rita to the RCA. If you want to do that, you need to advance to a fully total endoscopic coronary artery bypass grafting. This type of procedure democratizes the use of bilateral internal thoracic artery, is ideal in large chest patients, and offer definitely superiority of view, as you can see here. We are waiting for the release of a stabilizer for the newest DD5 generation of the Da Vinci. In the meantime, together with my team, we created and we came up with and published the technique to perform this type of surgery. And you can see that we are adding to the free general trocar 2 more sites, one for the stabilizer, one for the working port. We insert this first an Alexis retractor and the Apply Medical gel port with the stabilizer mounted from the subxiphoid incision, and then we re-enter in the chest, and this one is inside the chest. The stabilizer is placed, in this case, to the LED. We bring the camera to a 30 degrees down after placing, you see here, the working port in the second intercostal space. And now we have the opportunity to really see the target, prepare the target, and perform our anastomosis. And if you have the skills of an off-pump via sternotomy, performing this surgery is not complicated. It's just a matter of organization and preparation of each step. Here we are closing the LED, preparing our distal target, and then starting the anastomosis, opening the target, placing the shunt, as you can see here, and then start the anastomosis. Reopening, and you see how nicely you can visualize. Every stitch can be seen very clearly. Here, stitch on the lita, and again, stitch on the LED. And you see very, very nicely how you can manage the suture. I'm currently in our latest iteration of this surgery. I'm adding a fourth arm that I assigned to one of my fellow in a second console, and so they can help managing the suture, following, retracting, so making the surgery more feasible. And this is the technique that allow me to perform 2 or 3 bypasses in this type of setting. And I just wanted to share a patient's experience that is always generally more important than
a retired physician, and my apprehension was my remembering of my experiences training at the Cleveland Clinic and people undergoing open heart surgery.
And how many days you have been in the hospital?
I was discharged 26 hours after the procedure.
How did you feel back then?
I felt really comfortable. Once all the chest tubes and the arterial lines and the IJ line was removed, I felt very comfortable.
How many weeks we are from surgery?
I'm 10 days out of surgery.
Wow. Pain? Have you had pain during this time? Do you have any?
Minimal. I've used Tylenol a couple times a day in the beginning, almost out of just, I think I should use it because I want to stay ahead of the pain, but in these last 5 days, I've hardly used any of it. I had dental extractions that were more uncomfortable than this procedure, literally, no exaggeration. If anybody has had a root canal, they know what I mean.
I think sometimes patient experience is more powerful than a surgeon try to convince you to start TECAB while you woke up at 3 o'clock in the morning. So this one are also some of the opportunity. You see, this one is a Lima to the LED perform, and I'm giving this indocyanine green, is a hydrosoluble contrast that doesn't have any type of contraindication, and we can visualize the arterial phase. You can see nicely the pulsatility via our anastomosis. We open the bulldog on the mammary, and we see now the green coming down the subclavian artery and left internal thoracic artery to the LED. So together with the TTFM, or qualitative analysis, we are changing the dynamic with our cardiologist, offering a minimal invasive procedure to your own set of open sternotomy CABG, allow you to stop complaining with your cardiologist always that they are not feeding you with enough cases, but start to be on a boat with your interventional cardiologist, collaborating more with him and creating a team for serving more patients. I believe the future is very bright. This is my daughter performing and playing with one of the robotic platform, doing an incredible job. And she has never tried that before, and she's doing all of the exercise with perfect scoring. The generation that is behind me is even better than my generation in using the robot. So I believe that the future is going in this direction. You see here Dr. John Pascas trying the system, and my daughter clearly looking at Dr. Pascas because the system was keep defaulting when he was playing with it, saying, please just move away, I'm better than you are. So I think that the future is very bright. There is a huge role for bilateral internal thoracic artery TECAB. That's the way in which we need to do it. It's not for everybody, but the most important message you need to start for now is not for everybody. But the most important message you should go home with is you need to advance the skills in your coronary artery bypass grafting, start to use a second arterial conduit in your open sternotomy, become facile with off-pump techniques, and start a minimal invasive robotically assisted thoracotomy procedure in your own center. Those are the homework that you need in your own center, in your own activity. Start to do it right now. I want to thank you so much, all of the organizers, for this. And I love the t-shirt. One of my patients came to my office recently that state, stents are for wimps, real men have bypass surgery. So I think that we close with this one. Thank you.
Thank you, Gianluca. A magnificent presentation. And in the interest of time, we will leave the discussion after the last presentation. And it's also a pleasure for me. We know that still the world is driven on pump in coronaries. Off pump is a minority. So and robotic surgery is also option for on-pump surgeons. So I'm very interested in the presentation of Johannes Bonatti, which also does not need presenting. It's the name speaks for itself. So Johannes.
Thank you very much for the kind introduction. Just a second, let me share my screen. Are we there? Can you hear me?
Yes, we can hear you perfectly.
Okay, again, thanks for the kind introduction and the invitation to Prague, virtually at least. The term arrested heart TECAB sounds a little wild. We don't arrest anyone here, but we use cardioplegia for doing a completely endoscopic coronary artery bypass grafting procedure. Just to mention here, TECAB is still, I guess, the only procedure in the world that can only be done robotics. Any other techniques with thoracoscopic instrumentation, VATS, whatever, have failed to perform TECAB. And for me, it is a very viable version to do this with cardioplegia. Just for your understanding, I'm also doing beating heart TECABs here, depending on the comorbidities of the patient. We use the Da Vinci Xi system. Here, we all know that the endostabilizer is not available. So specifically in this current phase, the endoballoon provides a viable option. We prepare the intraclude balloon. We have installed the cannula. We feed the guide wire and the catheter into the ascending aorta, and then we inflate the balloon, shoot adenosine into the aortic root, which stops the heart immediately, and then del nido cardioplegia follows. Once we have achieved adequate rest, we go for performing our anastomosis. It's the exactly same technique that Gianluca has shown earlier on. For those who get started with this procedure, I would claim that the endoballoon is a perfect intermediate step. As you see here, you don't work on the beating heart. You have perfect still conditions, and you can take full advantage of the completely tremor-free work that you can do with the surgical robot. Everything is magnified. It is very important, as you see here, to put adequate suture tension all the time, and you frequently pull on the slings that you have. Instrument ties are perfectly to do with this machine. We open our endoscopic bulldog. They are specifically designed for this operation. And by the way, the sutures that we use are also specifically designed double-armed short polypropylene sutures that are used for this purpose. Again, elegant work, fine work, magnified, ergonomically super conditions. You see here, no bleeding. We inspect our graft. We deflate the endoballoon and wean the patient off cardiopulmonary bypass. I was asked to speak about current results, and I thought I'd show you our current series since 21 when I came to Pittsburgh, 147 arrested heart TECABs with cardioplegia, 92 of them, 62% single bypass, 54 double bypass and 1 triple bypass. When it comes to IMA harvesting times, I have, of course, many years of experience with that, but for the Lima, currently we take 39 minutes, for the Rima, 38 minutes. Important, cannulation is 55 minutes, which includes insertion of the endoballoon, and the cannulation is done most of the times in parallel to the IMA harvesting, whenever we can, whenever I have a colleague who can join me in this operation. LED anastomotic times 25 minutes, OM anastomotic time 22 minutes, a little shorter. Those times in our hands are roughly 10 minutes lower than on the beating heart because it's technically more appealing, easier if you wish. Flows in our grafts, 39 and 36 minutes for the LAD and OM graft. How long does a TECAB arrested heart take? So with all single vessel and double vessel, roughly 5 hours and 14 minutes. And we now have these automated performance metrics, console time 227 minutes. Very important, that has not been shown so many times. For the TECAB operation, you need on average 10 instruments. That's more than twice what we need for a mitral valve repair, for example. And there's many instrument changes, 62 per operation, which I think adds to the procedure time, and this is where we can probably improve our times the most with the instrument changes. How long are we on bypass? 108 minutes, a little more than 1.5 hours, and the cross-clamp time for all these procedures, 75 minutes. We converted 8 patients, that's 5.4%, and extubated 51%, so half of our patients in the operating room. Concerning the very hard endpoints, I think this procedure is doing very well. So we had an STS predicted risk of mortality of 0.8 and an observed mortality of 0.7%. One patient, that's an observed to expected ratio of 0.9. Stroke, predicted risk 0.7, that's exactly what we had also. One case, renal failure, predicted risk 0.7%. We had no renal failure, and of course, no deep thoracic wound infection with a predicted risk of sternal wound infection of 0.1. So all our observed to expected ratios are 1 or below 1, and that's, I think, speaks to the procedure. Blood transfusion, 17%, despite using the pump. Importantly, we experienced in these procedures no leg ischemia and no retrograde aortic dissection with proper patient selection, of course, with CT angiograms. Hospital stay 4 days. And if we look at our 3 years results, those are very satisfactory, 99% survival and freedom from any re-intervention or reoperation, 97%. There were 2 PCIs on follow-ups, one of them not related to the original procedure. That's where we are now with our results, and I'm happy to discuss everything with you. Thank you very much.
Thank you very much, Johannes, for an excellent presentation. And again, thank you for all the support through all the years we were doing the robotic program. So let's move to the last presentation. So both the presentation of Gianluca and Johannes were for us something like scientific fiction in Europe. And let's go back to more real world, which is the most common procedure in Europe and will probably be for some time. And I would like to ask Hristo to give his talk, Robotically Assisted MIDCAB in Practice, Lessons from Real-World Experience. Please, Hristo.
Thank you so much. I'm just waiting for my slides. Okay. I'm a newbie in the robotic world. I just started last year our robotic program, and I have to say I was not convinced from the very beginning. So the question I want to address first is why, and it's an important question because everyone who starts a robotic program will have this question in mind. And for me, it was not clear. We in Vienna, we have had a very extensive MIDCAB program for the last almost 17 years. So we've done more than 600 MIDCABs since last year. We follow the patients up. We have great results with them. And the standard procedure is about 1 hour. So I was not convinced, why should I do a 3 hours procedure? And then also we have a multi-vessel program, which also works very well. We produce good results. So nothing was pushing me towards robotic surgery until I saw that picture. One day, I think 2 years ago in Twitter, Gianluca posted a double vessel of pump TECAB post-operative photo of the patient that looked like this, and it amazed me. I realized that I could offer a treatment that takes the anxiety out of my patients, and the willingness of my patients to accept surgery as a treatment option will rise in contrast to other methods. So how did I start? I started recently. Well, as you could expect, console training about 4 months ago, and I was very hard working at it. But there also come the first barriers. As a everyday training surgeons, I do almost every day 2 surgeries, so I had no training for console training. And even if I did have time, there were surgeries taking place during the day. So the only time to train on the robot for me in the clinical scenario was during the night. So you can imagine that it's a demanding thing to train during the night, operate during the day. On 4 months time period, it gets exhausting. And then furthermore, we don't have any dedicated training programs in Germany. And so that's why I thank you for bringing this robotic summit, Stepan and AMS, Lorette. And of course, the third one was the limited number of proctors. However, I found some people who were willing to show their knowledge. I came here to Prague and spent some time with Stepan, and also went to Duisburg with Jochen Bergermann and Edis, where I could get initial idea. And what I found out, it is very important to pay attention to all small details when you visit people. I try to create written standards, ask a lot of questions, and make photos of every setup, of everything, which is very helpful not only for me, but for the team that you have to educate when you come home. What also is very important, try to remember all the settings of the instruments. What is the setting of the bipolar? What is the setting of the monopolar? What is the setting of the CO2 inflation? And these are some of the photos that I took during my journey. And when I came home, I gave them to the nurses and the whole personnel. So this is something that facilitated our start. And I also make mistakes. The first mistake I made I went on observation on myself. I didn't take any nurse practitioners. I didn't took our pump technicians, which I found out resulted in the fear of starting a program in the nurse and in the pump practitioner. So we tried to overcome that fear. We did a lot of simulation training with docking, undocking with our team. We simulated MIDCAB surgery without doing it, positioning the patient, docking, and we also try to simulate emergency situation where we have to convert or so this was something that helped the team to gain a bit of trust in the procedure. The next question that I fronted was the patient selection. I found out that you have to select at least 2 patients for your first case, as the possibility of one patient becoming anxious, getting sick, or having any other problems is there, and it can compromise months of preparation and team coordination. Then my experience showed me that it's better to select male patients, bigger chest, not obese, and having good coronary targets takes a bit of stress out of the procedure. Important is to take care of the logistics, to consider that sometimes delivery time for the instruments that you don't have in the hospital may take longer than you anticipate, which can also ruin a whole set of preparation. And the most important is you have to motivate your team. You have to build a dedicated, I truly believe, young team. You have to try to train and simulate together as much as possible and have fun. If you don't have fun with the procedure, you'll never be able to do it. And this is my first patient that I did in December 25. We managed to discharge him on day 2, and he's doing well. And I want to also show you, very transparent, my learning curve. For the first 5 patients, I started with almost 2 hours of memory harvesting, and we managed to go down to 70 minutes on the 5th patient. I'm looking forward to reaching the 39 minutes of Johannes. I think that will take me some years to do, but that's now my next goal. And having that in mind, I want to thank you for the privilege to be here and to talk about robotics.
Hristo, thank you very much for this excellent talk. It's always nice to see how you see the situation from the other side. We, as people who have been doing it for some time, we are locked in our mind. Sometimes don't see your needs for the training and things like this. When we were putting this program together, we thought 3 hours talking about robotic cardiac surgery, will it be boring or not? Will there be enough topics to touch? And I think we have already had 5 excellent presentations showing some different aspects. So let's start talking about the robotic cardiac surgery as a platform for all procedures. So do you think is any of the robotic cardiac procedures at the moment, is it a gold standard for the treatment of one of the heart pathologies? What would the panel think about this?
I would urge Gianluca, Johannes, and Jan to as people who have much more experience than myself to answer. I think it's a platform that will help cardiac surgery to reach our patients. What I found out in my very limited experience, that the willingness of patients to accept cardiac surgery as a treatment option is much, much bigger with robotics. I don't know why. I think we need some psychologists to explain this. But of course, we have to prove on a scientific level that the trauma and probably the psychological anxiety aspects are less. But I'm eager to hear your thoughts. Gianluca,
Yeah.
If I can, to start.
Yeah.
So I think there is, no other way than to go or to proceed in minimally invasive surgery, because it's a must if you want to compete with interventional cardiology. And there are different platforms. For instance, this transaxillary platform, which also serves as a night platform for not only aortic valve but also for mitral valve, tricuspid valve. You can do whatever you want. You can do multivalvular procedure, but it's still a little bit invasive approach because it's not fully endoscopic approach. still requires quite big incision, even so in axillary region. And yeah, we are also using this platform at our department, so I know what I'm talking about. And robotic surgery is much less invasive comparing, for instance, transaxillary platform. So I think this is the way to go, because using this lateral approach, you can address also not only mitral valve, but also, as we were talking, aortic valve, tricuspid valve. You can do multivalvular or complex combined procedure, but it requires high expertise. It requires support from the company, which we finally have, and we need more dedicated instruments. But I think it's the way to go when we see that it's from latest results of randomized trials in low-risk patients. The results of TAVI are, I would say, suboptimal. So it's a window of opportunity for us, provided we can do this procedure in a minimally invasive fashion.
And do you think, is there enough evidence for us to say robotic is better than, say, minimally invasive or sternotomy approach for any of the pathologies, or are we still lacking this evidence and we will need it for the future?
Well, we are definitely lacking this evidence. We don't have such evidence. We have some evidence. We don't have any randomized trial. Probably we will not have them, but we need more multicentric trials. So there is not enough evidence to say that robotic AVR is better than partial sternotomy or transaxillary approach. We have some evidence regarding mitral valve repair. Even so, it's not randomized trial. We have data from US comparing thoracoscopic approach, robotic approach, and conventional approach through midline sternotomy, and these data are showing that robotic approach actually had better results comparing the others. That's all we have. We need definitely more evidence.
So this is the quite famous US study. It comes from the STS database. Can you, Johannes or Gianluca, comment on this trial?
Gianluca, you're muted.
We can't hear you.
Now you are.
Can you hear me?
Yes.
Oh, fantastic. First of all, I want to say congratulations, Hristo. Was a beautiful presentation. Let me tell you, it was a fantastic. Thank you for sharing it. It's such enlightening to see how someone very versatile with off pump and with a MIDCAB, a multivessel MIDCAB, finds the time, efforts to embrace a new technology. And you know, we all tend to follow the second rule of the second law of thermodynamics, even as individuals. We try to minimize any entropy, and so anything that is new, our job is very difficult to implement, particularly when you become attending and you are very busy with your clinical practice. So kudos to you and your team for what you presented here today. It was very, very impressive. Going back to the question, yes, I do believe, and as Stepan said, and I like the STS is really putting a lot of efforts to try to create a consistent and overall scientific background to robotic cardiothoracic surgery. We don't have evidence right now of superiority, but I think we shouldn't, it's not that we need to prove a p-value of superiority of a procedure respect or something. Reality is that robotic allows you to perform the same type of mitral valve repair, if not better, from a side than what you would have done via a sternotomy. I personally believe that a robotic approach to the mitral offers you a better visualization of the mitral than what you can have from the sternum. So you allow a surgeon to have a better visualization of the valve, perform a better type of repair, and offer the patients a more cosmetic and fast recovery type of procedure. That's how you convince a patient who is asymptomatic to come to the operating room. For years, we have tried to fight for having asymptomatic patients in mitral valve disease with severe mitral regurgitation to the operating room fast enough. Cardiologists were always holding them back and try to basically refer to surgery only when symptoms or atrial fibrillation were manifesting. The reality is that robotic allows you really to reach more patients and to treat them in a different time. I don't think that we need to prove a p-value to prove a superiority. I think that we are on the verge of a time in which the entire community start to understand and is starting to understand that both in valves and in coronary, there is a huge opportunities. And if we miss it as a whole, as a community, we're going to miss the opportunity for tons of patients to receive a better type of treatment rather than a TAVI, rather than a mitral clip, rather than a multi-vessel PCI. So it's on us start to really create an effort to learn the skills and keep performing the surgical procedure that we have always learned via sternotomy with the same outcomes in a less invasive way.
Yeah. Can I expand a little bit on the evidence part of the discussion? So I had the honor to present the STS database results of robotic coronary surgery over 20 years at this year's annual meeting, and it's in the works for publication. Fact of the matter is that in the beginning, in the early 2000s, roughly 1,000 procedures, robotically assisted CABG, were carried out in the STS space, so to speak, in the United States of America and Canada. And this grew only over the last years to about 2,500 procedures per year, which is now 2.3% of the CABGs performed, so still a very, very low number. Results-wise, however, we are doing very well because, as I had shown you earlier on, at least as compared to the predicted STS risks, these procedures do very well. We're reaching only 50–70% of the predicted risk. So that is a very positive signal. Conducting a prospective randomized trial at this point, and I was involved in the attempt to do a hybrid trial here in the US, extremely difficult because you don't have enough centers to even accumulate the hundreds of cases that are necessary to prove something. So that's where we are, but I'm fully aware that prospective randomized evaluation would be necessary. How we do that realistically is a big question.
Thanks for the comment. We can expand on the mitral a little bit later because now I think I would like to ask Jan, because their center is very experienced and has a very long history in open MIDCABs. You have done more than 1,000 open MIDCABs, and I know that you did some prospective or retrospective matching group study on robotic MIDCAB against the open MIDCAB, and you are currently running the prospective randomized trial on the same topic, which can be very interesting. And can you comment on this?
Yes, Stepan, it's true. This randomized control trial is still ongoing. So I cannot provide you any data or a result now. So we'll see. It's still ongoing. We did some propensity matching analysis before, comparing conventional MIDCAB and robotic MIDCAB, and the result of this study was slightly in favor of robotic MIDCABs. But we decided, to proceed with prospectively controlled randomized trial, which is still ongoing.
Yeah.
And it's true, our department has a long history of MIDCABs. as we have performed more of 1,000 procedures in conventional manner so far. But since 2018, when we started our robotic program, most of the MIDCABs are now performed in a robotic fashion. So, for instance, I used to do MIDCAB many years ago. It was even my first procedure in cardiac surgery, which I did by myself, of course, under the control of a senior surgeon. But after a few years, I just stopped to do this because I was always, a little bit nervous about if I will be able to harvest the mammary artery long enough. I was nervous if when I open pericardium, if there will be a nice target and if lima will be long enough, to reach this target. So I decided to stop and, I didn't perform, for many years any MIDCABs. But I started again because, robotically assisted MIDCABs, for me, is a game changer because you can harvest the entire length of lima from its bifurcation to its bifurcation, and you can identify the nice target first. So for me, it's really game changer. And also lima harvesting, comparing conventional harvesting, it's much easier and much faster and much safer. So that's from my side.
So one point about IMA length. I have proctored quite a few robotic centers, and always the open MIDCAB surgeon struggles with shortening the IMA because, as you said, in an open MIDCAB, the IMA is always just the right length and can be short. With a robotically assisted MIDCAB, it's exactly the opposite way. It's almost always too long, and you have to shorten it quite a lot. Yeah. So let's stay in the coronary field. We had 3 presentations on different techniques. So what do you think will be the future of robotic coronary vascularization? I also liked your comments, Gianluca and Johannes, about the setup and the anastomosis, and I think the TECAB, either arrested heart or beating heart TECAB, it's very similar to mitral valve repair regarding the repair or the anastomosis itself and the setup. The setup is always more difficult than the anastomosis or the repair itself. Once you have either the heart arrested or you have the stabilizer in, then it's quite easy to open the artery, insert the shunt, and do the anastomosis. But so, what's your thoughts about future of robotic revascularization? We can't hear you, Gianluca. We can't hear you.
Can you hear?
Yeah.
So I don't know. I think that honestly, Stepan, the future of coronary vascularization should be a form of robotic assisted MIDCAB. That's the first step. If we can, in the next 3 years to 5 years, start and create consistent data of increasing number of robotically assisted MIDCAB procedure performed around the world, I think overall, as a community, as a group, we were doing something really good. If you see the STS data, and Johannes is going very soon to, we have worked together with Johannes, try to recatch a picture of what is the percentage of robotic procedure in coronary performed at the STS by the STS database. We are still to a very low percentage. It was 1% few years ago, is slightly better, but we are still single digit, 1 or 2% of the entire coronary artery bypass grafting. So I think that as a community, the first things that we need to do is increase this percentage. Can we bring it to 10%? Can we bring it to 20%? And I'm talking about robotic MIDCAB. Can we safely bring it there? Can we start programs? Can we have more people start feeling very comfortable in taking down a memory robotically or via sternotomy? Should be part of the training, should be what a present and future fellow in cardiothoracic surgery should be able to do it. From there, I believe Johannes and I both will tell you that the future is not doing a thoracotomy. It's an endoscopic form of TECAB, on pump of pump. Everybody can cook their own lasagna in the way in which they wanted. Okay, my mom and my aunt do great job, but they cook very different lasagna. They're both great. There is no one better than the other one. Okay. So reality is you choose what is better for you, for your center, for your background, for the way in which you approach. But I think the future is for sure TECAB. How to get there right now is not something that we should be open to everybody, because the risk is that complication happens if we are too loose, and then we make a name or a bad name for the procedure itself. So we need to be protected, but we need to have a steady growth. I will be very happy if the number of robotic coronary artery bypass grafting in 5 years has reached, I would say, 10%. That would be an incredible result, or even 8%. That would be an incredible result as a surgical community. That's what I think. Johannes, what do you think?
So I think there's an echo now. Okay, now it's good. I agree with what you are saying, Gianluca. Into the future, I see more demand in the training space rather than on the technology space. I think that the machine is there. The procedure, even the TECAB procedure, is reasonably well developed and almost standardized, I would say. So it is more to get it on a broader basis. We have to teach our colleagues properly, and I'm coming back to what Hristo has said. It is just necessary that you spend hours and hours and hours in the training lab to learn the technical details. I think there is most of the demand. I don't think that anastomotic connectors will be the solution to the problem, because, as has been mentioned, this procedure is more about everything else than the anastomosis. If we look, I just did a quick calculation. 27 minutes out of 314, okay, is only 8% of the procedure is the anastomosis. Everything else is where we lose the time. The anastomosis is not the problem. Once you have established a good exposure of your LAD or whatever target vessel it is, then comes a nice part. Everything around is the annoying thing. And I think leading people through those elements of the procedures properly and training them there well is the way into the future.
So I think we are getting to two very important points. The first one is the evidence to show that this technique is good, can be spread around the practice. The database is very important, and the training. We have this impression from both sides, from the starting surgeon, starting program. Again, it was an excellent presentation, and now we can see it, and we can define what steps are necessary for the future. How to train people, how to get them safely trained, and how to increase the number.
I think having a written standard how to start, and I think the easiest way to apply is really the robotic assisted MIDCAB. It's safe for the patient. The worst that can happen is you destroy the memory, but you won't have any severe cardiac complications from that. You convert. Having written standards that are written from experts like you is a very important step, and this is something we have to work on. And if we want to go up to 20%, which is the patient selection, which are the steps, how to get there, and establishing dedicated conferences like this one, webinars, and talking about robotics. And also very important is we have to publish. We have to be academically active in the area. If we don't publish, we won't make an impact.
We have been actually working on this, on the European guidelines for establishing new programs, and it will be hopefully published soon. There's been a lot of work. But there's one more important thing, and it's probably, Johannes, you have been in robotics for a very long time, and why was the adoption in the past that low? What mistakes we did at time? Did we make a mistakes as a community, as a surgeons, or were the mistakes made by the company, by the manufacturer, or was it a mix of mistakes?
And probably the technology was not developed enough, or...
Can we learn from the past and not to repeat these mistakes?
I think the first challenge was that the first ever procedures done robotically were too complex. I mean, starting out with TECAB and robotic mitral was just a stretch. I mean, only by the activities of urology, gynecology, general surgery was robotics on a broader basis for the community surgeon even. And that, in fact, helped us in the end to get it back into heart surgery. At some point, we were almost dropped by industry, okay, because of the slow adoption. So that was one thing, too complex procedures in the very beginning. Then I would say probably some impatience in our own community, and key opinion leaders that have tried it out didn't advance and then declared the technology as not useful. I think that was a big mistake. Instead of at dedicated centers continuing to develop the procedure, get data, move on slowly, it was also almost destroyed at public conferences and meetings by people who had given it a try and declared it as not useful. And another factor is, of course, still the high costs of the procedure. No doubt. One hope would be that with the number of new technology companies that are coming in, that at some point robotics will become more affordable. Okay, there's so many countries where there is no reimbursement, and that is certainly still a big factor, and the training methods, of course.
And why do you think why is the right time now? What changed? Are we ready now? Is the technology ready? Is the community ready?
I clearly think that, Stepan. I mean, as mentioned, it has helped us tremendously that robotics is so established in other disciplines like general surgery, urology, even thoracic surgery. And here in the US, there are so many young cardiothoracic surgeons coming out who come with established robotic skills into heart surgery. So this is a completely different landscape. plus the new technology that is coming in, which creates competition and technological development. I think it's really the right time to move forward.
This is a very important point because the surgical training in Europe is different from the surgical training in the US. In the US, you go through a general residency, so you are exposed to robotic technology. You are, as a general resident, you are able to perform some robotic procedures, and then you move to cardiac surgery with the robotic skills. Yes. In Europe, it's different. We enter the training, the dedicated training in cardiac surgery, and you are exposed to robotics only in the centers performing the robotic surgery. So
if I may expand on that, Stepan, there are two tracks in the US. We also have 6-year programs. They are still cardiothoracic, but they have a strong cardiac focus. But I would say that those who come out of a general general surgery training have a bit, concerning robotics, have a bit of an advantage because they come with established skills. They have done gallbladders and hernias and whatever. They sit at the console and get started.
Gianluca, we can't hear you again.
Sure, why every time I start talking. Can you hear me now?
Yeah, we can hear you now.
Fantastic. I don't know what happened to my microphone. Probably goes on a pause, and I cannot. But it was a fantastic conversation. I think this is, as Johannes stated, and you, Stepan, stated very well. I mean, it's a different time. You have also to remember. I was not around for that time, but I mean, when actually I was a very young resident. I remember attending the first STS I attended in 2014. I was a first-year resident. I remember those were the time in which a national meeting there were still debate sternotomy versus minimal invasive. Forget about robotic. We were not even accepting as our overall surgical community of cardiothoracic surgery any form of minimal invasive procedure, mini AVR, mini mitral. Like we were really not exactly open to consider. And as Johannes said, even important leaders of our discipline have been in contrast or in conflict with any form of minimal invasive procedure. And when that is the setup, it took us a long time to recreate a position of where minimal invasive sit currently in the world of cardiothoracic surgery. Then once we have understood as a whole, as a community, that if we wanted to operate patients, asymptomatic patients, if we wanted to stay relevant, if we wanted to maintain, to offer the benefit of surgery to more patients, we needed to adopt a minimal invasive form. In the world of minimal invasive, I believe robotic is a beautiful and natural evolution that allows that platform, Stepan, as you said, that allows you to perform not one single procedure, but multiple of them and multiple changing and shifting the paradigm. So you're not spending a lot of time in training yourself in mini mitral, and you do like you learn, and you with your team learn one platform that is a robotic platform, and once you're skilled in that, you can apply in aortic, you can apply in mitral, you can do congenital cases, you can do coronary cases. So you have an opportunity to really breathe the entire world of cardiac surgery.
If I can add up to your thoughts, Gianluca, if we look historically, I think the first publication of a minimally invasive mitral repair was 1996. So it took almost 10 years before minimally invasive mitral surgery started spreading on a larger basis. And it is the competition from transcatheter technologies that was probably the leading factor. You can see that with the advent of TAVI and with the advent of tier, also parallel to it, minimally invasive surgery started spreading. So I think in that setting, robotic surgery has one huge advantage, and it is the teaching platform that it can offer. The second console, where I remember my times when I was a resident and I was assisting mitral valves in sternotomy, I was never able to see the mitral valve. For me, it was a mystery what the surgeon was doing. So having the possibility from the very early stage to see every single step in detail and then train it on a simulator is very important.
And I will tell you, it really makes a big difference having two consoles for training the centers and the surgeon, because you can show them the movements, you can show them what to do, you can take over for part of the procedure. And we put it as a mandatory requirement for the intracardiac procedures for the European training, to have the second console in the OR when you start your intracardiac program with the proctor. And I think we should really make it mandatory and don't skip this requirement.
Yeah.
So I think, yes, Johannes?
Yeah, as Hristo, as you mentioned, that what was going on the other side of the table was some kind of mystery. Robotics and videoscopic techniques have demystified the mitral valve. And also what is available these days on the net concerning video material of procedures, okay? It's a completely different world. People can prepare for these procedures in a completely different way. And by the way, in these EACTS guidelines that will come out, we had one sections where we clearly comment on the value of video studies in the training for robotic surgery, and there are recommendations which movies to watch. So this digitalized, video digitalized world will make training for robotics much easier, let alone the virtual training models that are available.
There I really want to move the discussion to, do you believe there is a straight pathway to robotics without starting open thoracotomy mid-cap? Or is it more wise to have some experience in minimally invasive surgery? From my point of view, I can say I started doing minimally invasive mitrals before I did my first sternotomy mitral. So I had some simulation training. I did probably about 10 minimally invasive mitrals, and I was afraid of the sternotomy because I was afraid of not seeing the valve the way I see it through the thoracotomy. Is that way also possible for robotics?
Yes.
I take this question, and I hope my microphone is on. Can you hear me? Just I want to make sure. It's I believe that in the future, yes, in the future, and as Johannes was stating, the new residents that are coming to the mix, particularly those that have previous experiences in robotic, probably their natural evolution, I mean, I don't know, there will be someone that will learn very soon how to take down a mammary artery robotically before knowing how to do a mammary artery via sternotomy. That's the reality. You see way better the mammary in a robotic rather than in a sternotomy. I think our generation is still the one that transitioned to, but the next generation and the generation ahead are the one that learn directly that type of procedure. You Hristo, are explaining very well. I think that there is a generation who have learned via sternotomy, the mitral valve, and really advanced the field and brought it to a mini thoracotomy approach. And then there is a generation to follow that have only seen mini thoracotomy and actually feel more confident to start with a mini thoracotomy approach and is more scared than a sternotomy. So I think that the future will be a future where people will feel more comfortable to do a TECAB than an open sternotomy CAB, you know. How long it will take, I don't know, but I think that there will be, for sure, this is the way in which we have to imagine. And there will be people going directly to robotic mitral or directly to robotic AVR. We are still in the transition phase. I don't think that we are there yet, but I imagine soon a generation of trainees that learn robotics from the get-go, from the starting.
I think we should take lessons from the general surgeons, because I'm unfortunately old enough to remember the days when the laparoscopic cholecystectomy started. And I remember the discussion. You have to do first 100 open cholecystectomies, then go to the laparoscopic cholecystectomy. And now, of course, the general surgeons start with the laparoscopic cholecystectomy, because the uncomplicated open cholecystectomy doesn't exist. It's just for complicated cases. So we will get to this stage as well. And you are right that the German surgeons, they start with a minimally invasive mitral, because the penetration of minimally invasive mitral in Germany is 60% of
yes,
all
I think
mitrals,
around,
or something like that. So the young surgeons start with the minimally invasive mitral, and I think this will happen with the robotics in the future, because I think the robotic mitral valve repair is probably very close to be labeled as a gold standard, or in a very close future. We have a lot of data, we have some evidence, and it's really probably the best way how to repair the valve. And in Europe, I believe it will be, in the next 5 years, it will be expansion of centers performing robotic mitral valve repair. Because all the German centers, the 60% of cases, will be in the next 5 years shifted from the minimally invasive to robotic. So you are based in Germany. So is it a correct impression?
I don't know if it's next 5 years, but I'm sure that that's the way. I see only the last months a number of German centers starting robotically assisted coroners. I think you've assisted almost exclusively all of them, so you have a great view of that. It is a technology that is going to transform the field of cardiac surgery. However, I don't know if we'll get the percentage of robotics that urologists now have. I think there is some, probably for robotic mitrals we might, so I don't know, how do you see it, Stepan? How do you think, what is the percentage of coronaries that we might get robotic, and where's the limitation?
It's a difficult question, especially for me, who is not a coronary surgeon. My main field of interest is intracardiac, and the answer will be very, very broad and structured and complicated, because it's about a diagnosis, about strategy. Is really the sternotomy, CABG, IMA, and 3 veins. Is it something which helps the patient? Do we treat the patients in a correct stage of the disease? We are talking about preventive operations in AVR, in mitral. There is the concept of the surgical collateralization. So this should be probably the question for Gianluca
and Johannes and
Johannes, because we had a lecture from Gianluca 2 days ago about the future of treatment or strategies of treatment in ischemic heart disease. And it's probably beyond my surgical thinking how to perform the CABG. It's about the diagnostic strategy, cooperation with the cardiologist, the referral pathways, and but if I can talk about my or our current practice at the department, we are currently doing 18% of all our cardiac cases robotically, so just below 20%. But 70% of our robotic practice is intracardiac work. And in the coronaries, the percentage of robotic cases will be something like 5%, no more. And we do mainly isolated LAD lesions not suitable for or type C lesions not suitable for stenting. But if we have more access to the robot and we want to expand the revascularization program a little bit more, we would start looking at some triple vessel cases and converting them to hybrid approach, to bilateral IMAs. And we can probably go up to 20-30% of all robotic or coronary cases.
So we come to the next day. Is hybrid the future of coronaries? Robotic hybrid procedures? Gianluca, Johannes, Jan?
I give you my answer. I think that the future of coronary depends on which type of patients, okay? We have been using the same type of procedure for all comers. Nowadays, with CT coronary and CT angio, a large majority of patients detect their coronary artery disease at the time in which they are completely asymptomatic, they are in younger age, they might have some risk factor, and they come to you because the interventional cardiologist cannot stand all of the lesions, or there is a appropriate non-interventional or interventional cardiologist that see a diabetic young guy that comes to your office and look for a surgical opinion. This type of patient is currently treated with the same type of procedure that we would offer for a patient who come in the hospital via the emergency department with an acute coronary syndrome, a troponin release, an ejection fraction of 40%, a series of lesions in their coronaries. So we are offering the same procedure that is sternotomy bypass for all comers. It's a great procedure, it's a great operation, but I think that these two subset of patients should probably receive different type of treatment. If you come with an acute coronary syndrome, your ejection fraction is reduced, you should offer a complete revascularization, multi-arterial, bypass grafting, on or off pump, whatever you like, via sternotomy, making sure the patient is stabilized and doing well. But if you are offering, if for the patient that comes from home and has triple vessel disease, a lesion that is easy to approach via stent on the right coronary artery, a series of disease on the left system, I believe that this type of completely asymptomatic skin guy, 58, he was ready to run a marathon, but his wife told him, you cannot train for marathon until when you don't do a CT coronary, and the CT coronary came back positive. This type of patient could be treated differently. You take one or two mammary artery, you deploy to the left system, and then maybe you offer a stent to the right. Maybe you don't even offer any stent. You just give him a PK9 inhibitor and you maximize his medical therapy, and you give the advantage and benefit of double mammary artery. The concept of what is complete revascularization in the current era of guideline-directed medical therapy and for patients with stable coronary artery disease, asymptomatics or pouchy symptomatics in normal ejection fraction is completely different than the guy that comes with a reduced EF and a balloon pump unstable to the operating room. So a coronary expert is that guy that knows how to make the judge of which type of procedure you should offer for which patients. I still perform 50% of my bypass grafting via sternotomy, and I hope in the next year, and I'm sure that in the next year, I will still perform 40%, 30, 40% of these procedures still via sternotomy, but there will be a larger majority of patients that will receive coronary with a robotic approach. So I don't think hybrid is for everybody. I think we need to select our patients and have surgeons capable of performing different type of procedures for different type of patients.
Can I step into that? The 50% plus that Gianluca just mentioned. During my assignment at the University of Maryland, I was in charge of the coronary program. I was a coronary surgeon at that time, exclusively more or less. And that's what helped me develop the TECAB procedure to multi-vessel, by the way. During that time, at least towards the end, we were doing more than 50% of our CABG procedures with robotic assistance. Okay, so I think this is an absolutely realistic number, but I think it needs the focus of dedicated surgeons. It needs the component of hybrid, because I think doing all multi-vessel cabbages or a huge proportions with triple vessel TECAB or whatever is a bit of an illusion. Too long, too complex procedures. But I think the key step that we did there also was development of double IMA grafting. I think if you can do double IMA to the left ventricle, one to the LAD, one to the lateral inferior wall, and combine that with stenting, that opens a much bigger segment of multi-vessel disease patients that are suited for robotics.
Sure. I remember there was, during the presentations, there a couple of questions popped up. I think one was for Jan, and it was, what kind of cardioplegia do you use? I think one of the participants.
Before we move to the questions, because we still have some time.
Significant.
I just want to follow what you just said. It's the strategy, the revascularization strategy. And Johannes, in your presentation, you mentioned some conversion rate.
Yes.
And which part of this conversion is a real conversion under emergency condition, and which part is the change of the strategy? Because what we did yesterday, we had for the Monday afternoon live TECAB case, we had 2 patients scheduled. We chose the one. The second was done yesterday afternoon, and he didn't have a favorable anatomy. So what we did, we just inserted the camera, opened the pericardium, look at the LAD, and the LAD was completely intramyocardial. No way how to do it with a robot or with a limited thoracotomy. So we took the IMA, skeletonized, then did a sternotomy and put the lima to LAD. And before that, we were discussing, before converting or changing the strategy, we were discussing the case online with the interventional cardiologist. And we said, look, you send us this guy for minimally invasive or robotic MIDCAB. We are not able to, with current techniques, with current skills, we are not able to find the LAD. So we will close the pericardium and send him back to you for a PCI. But it was a complex lesion involving the diagonal. So the cardiology guy said, look, he needs, he's 73, he needs cabbage. Our results are not favorable. So if you are talking about conversions, are we always talking about conversions or about strategy change?
Yeah, I'm, so to speak, a bit of a specialist with conversion, because I went through the early phase of TECAB when in the whole TECAB surgeons community, the conversion rates were 20% up to 30%, 1 out of 3, 1 out of 5 patients. And my colleague, Dr. Goebbels, wrote this up during my time at the Cleveland Clinic Abu Dhabi. The conversion rates have come down nicely to 5%, below 5% range in the community of TECAB surgeons. What I can say in the current area is that a smaller percentage of conversions are related to the primary goal of the operation. So we had to convert 2 patients only for a problem with bleeding from the anastomosis. No conversion related to destroying an IMA. The rest was things like the patient not tolerating single lung ventilation, adhesions leading to a lung lesion that could not be fixed endoscopically. So I would claim that with experience, your necessities for conversion are more in the space around the primary goal of the operation.
Gianluca, just a very practical question. You do the off-pump TECAB very nicely. What is your plan B? Do you put 2 sheets in the groin in just case the patient fibrillates during shunt placement, or do you go direct for sternotomy? Can you elaborate on that? You're muted.
You're muted.
Yeah. Again,
Still can't
muted.
hear you. Still can't hear you.
Hello?
Still can't hear you.
Yes. Now.
Can you hear me now? I don't know
Yes.
why my
Yeah.
microphone. I'm not muted, but I cannot. It doesn't work. Well, very good question. Yes, I do put a femoral sheet in patients in which I'm worried for low tolerance of ischemia. I generally have a femoral artery independently, always, all the time. And if something, if a conversion need to happen, for me, like a conversion to a TECAB is a robotic mid-cab. Okay, so means that there is a problem with my robotic anastomologist. I'm not happy, the flow is not good. And so I decide, or I cannot stabilize properly, so I decide to convert it in robotic mid-cab. My conversion to sternotomy, I mean, it's has been in the last 400 cases. We have 2 cases of conversion, and they were both very like elective conversion. There were no CPR done. We were not scrambling. There were a case in which I dissected a Lita when I was taking down a Rita robotically. I finished with my Rita. I go to my Lita, and I noticed they were both small ChatGPT patients that with my instruments, I damaged the Lita. So I have to figure out some strategical alternatives. And at that point, I converted to a sternotomy, but the patient was doing perfectly fine without any CPR or any acute event. I think it's all about preparation, training, team, and you can acquire that, particularly if you have a team that is facile with off-pump techniques. And overall, I want to cite Mark Ruel. Mark Ruel taught me that a conversion is not a failure. Actually, the failure is a failure to rescue. Is when you try to hide and try not to do the right things at the early beginning, and then you pay a price, or your patients pay a price because you have waited too long. I think that a conversion should be part of your natural and overall team building abilities. You should always avoid to get to the point in which the patient is fibrillating on the table, and you need to have techniques and skills for performing off-pump or on-pump coronary bypass grafting. You should be a dedicated coronary surgeon. But it's totally manageable. You need to be facile with a peripheral femoral cannulation, eventually putting a balloon pump and stabilize that patient.
I have just one technical thing. It will be 12 hours and 12 o'clock. And here in Prague at 12, it will be test of the emergency Wouter. There will be a lot of noise. So probably we should move the conversation to the online space.
Yes.
Very soon, and we will mute our microphones not to disturb the audience.
Yes.
So,
Gianluca, just to go back to what you said, and also to Johannes and to Jan being there, do you train with your team emergency dedocking and an emergency situation? Because you said they are very rare. So do you have, I don't know, once per 3 months a dry training, or is it something that you don't need as necessary?
I don't, and I hope my microphone is on. I don't, but I don't think it's a bad idea to do it. I should probably. So don't follow my example, but maybe making sure that we keep everybody alert and training for every emergency is a good idea. But generally, don't do it.
If I can, we also do not have dedicated training for undocking in emergency situations. But it's definitely a clever idea, and as Gianluca is saying, we should start to train this, but so far we didn't.
Okay, I mean, I think for learning teams to do those drills, extremely important. Okay, this is no doubt that this should be part of a standard training program, more often than one time. Drills, mock operations, how to handle these situations. And if I may come back to the question of emergency cannulation, so we meticulously wrote down all our cannulation times in robotic surgery. 45 minutes for non-endo balloon and more than 50 minutes if you insert the endo balloon. So 45 minutes on average, which means if you want to cannulate someone emergently, yeah, you can have wires, yes, that's fine, but it's a significant amount of time that you need to do that. One has to be aware, just has to be aware of that fact. You don't do that in 10 minutes. And then it's a crash, and then it's a crash cannulation with all the additional risks of perforating the femoral or iliac arteries. I'm a friend of prophylactic cannulation for that reason.
I have to say we trained this once under a real clinical scenario, and we were able to succeed it. But it's better to train it in not this clinical emergency situation.
Yeah, even though I must say undocking the system, for those who have not worked with robotics in this meeting, undocking is usually no problem. The machine has a backup battery which allows the undocking of the arms expeditiously. I really must say that this is no big problem, but the overall choreography of such a situation is important, that the surgeon specifically remains calm and controls the situation and guides the team through the necessary steps.
So we are in our last hour of the 3 hours, and Wouter Oosterlinck will be joining soon with a presentation of the AI application in robotics, and we should probably move to the questions from the online audience as you recommended. Can we see the questions on the screen here? Because we can't see just the and if you can go up to the first online question on the right side. Okay, a little bit more down. Okay, so the first question was this one. What's your cardioplegia strategy for robotic AVR with severe aortic insufficiency? It was a question for Jan.
Yes.
Yes, thank you. So we are basically using exclusively custodial as a cardioplegic solution in aortic valve replacement. In mitral valve, we switched to del nido because as we gained more experience, the cross clamping time is shorter, so we are using del nido. But for aortic valve, we still use custodial, and I have to say, in most of the patients, there is predominant aortic stenosis, so we can give cardioplegia into the root. If there is moderate or severe aortic valve insufficiency, of course, you have to give cardioplegia selectively, which is feasible. But what we are doing, we are always trying to give some dose, initial dose of cardioplegia into the root, just, to harass the heart and to give more time to securely open aortotomy and cannulate coronary ostia. So this is the way we do.
Do you think, do we need some support from the industry, for example, a percutaneous retrograde cannula, which was available in the past? Would it help with the pure aortic insufficiency?
It might help, but it brings more complexity to the procedure. This is the same like for me, intraclut. We have started with intraclut, then it was unavailable from some reasons, from company reasons, so we switched to a transthoracic clamp, and we are quite happy. I'm sure, in experience, and intraclut is always also great device, but again, it brings complexity to the procedure. So,
and you are right. We have the same experience with the pure insufficiency. We just give the initial dose into the root. The heart slows down, and when it stops bleeding, you just turn the cardioplegia off, put the vent in the LV on, and open the aorta and cannulate the coronaries directly. The second question is for you as well. Do you ever use sutureless aortic valve when doing robotics? I know the answer, but the question is for you.
Yeah, from time to time we are using. It's actually easier because you don't need, or you need 3 stitches, because we are using intuitive valve from Edwards. So it's not completely sutureless. There are 3 stitches which must be put on and then tied by core knot. There is another suture valve which is Perceval, but it's a high profile valve, and you would have to do your aortotomy quite high. And I would be afraid with robotic tools, then it would be very difficult to excise the valve. Even I know that Dr. Balki actually published, I believe, a case report when he implanted Perceval valve using robotic system. But generally, if you want to use sutureless valve, which is easier to implant, you have to use intuitive because it's low profile balloon expandable valve. So yeah, why not? It's good.
Thank you, Jan. And we move to the next question, which is for Gianluca. And I think it's direct to the point. Probably, Gianluca, you can explain a bit more. And this is which suture needle type you are using.
So I'm currently using what Johannes taught all of us, and he's using this Pronova suture that is old as a 7 centimeter. It's probably more of a 10 centimeter suture with a very small needle at the end. I think it's a 9-node needle. We are working together with AMS now, Peter Surgical AMS, to develop a new dedicated suture for robotic and for TECAB. My personal experience with Pronova is that we can improve it, we can do better, and I think we can really create a suture that is sturdy, but is on the other side has the ability to be facile with a robotic technique. So I'm looking forward to use these sutures. I think that there is a unique opportunity for a company that for years has been involved in the suture and has excellent skills in creating fantastic materials for suture and fine needle, and create something that is very unique and very high tech. So I'm looking forward to put the hands here in the US very soon of one of these suture and start to use them in my clinical practice.
Yeah, and Gianluca, you can leave your microphone on, as the next question is also for you. It is, do you perform concomitant surgery also with left atrial appendage occlusion?
Yes, I do. Actually, I think this is another beautiful opportunity for all of us. With the recent results of the trial that we have all watched presented right now at the American College of Cardiologists, that did show inferiority of Watchman in higher risk bleeding patients, respect of anticoagulation. Okay, so AFib patient that have higher risk of bleeding, randomization, one group get a Watchman and no anticoagulation, one group get just anticoagulation, even if they have higher risk. Outcomes at 1 year, outcomes at 3 years. Superior for the arm that took the anticoagulation alone. So Watchman was inferior to anticoagulation for high-risk bleeding patients. That creates a unique opportunity for us. I think that in my own hands, with my own team, putting a left atrial appendage clip robotically take us 40 minutes skin to skin, even less than that. We don't even put a follow in the patients. And I don't even put a chest tube. I mean, I put a chest tube and I remove it by the time in which the patients get to the ICU. Patients goes home in less than 24 hours. It's a very straightforward procedure. We have done concomitant to TECAB or standalone. We have done almost 100 of these robotic left appendage. The visualization is excellent. You can do in every type of cameras, even in redo patients. We have done some complex and challenging cases. You can dissect the left atrial appendage nicely and deploy the clip. So I think it's a unique opportunity, as well as a unique opportunity, the robotic treatment for atrial fibrillation. So isolated robotic treatment of patients that comes with no mitral valve disease, no coronary artery disease, but with a form of recurrent atrial fibrillation that percutaneous ablation were unsuccessful to treat. I think there is another big partnership with our EP colleagues and working with them to create something very special.
We perform it more and more as a concomitant procedure to MIDCAB Lima to LAD. You just put a thoracoscopically the clip, then harvest the IMA and do the anastomosis. Okay, can we move the questions a little bit?
Can you scroll a bit more with the?
Yeah. There is a question for Johannes. Do you check the patency of your graft with angio or CT scan in the follow-up, or how do you do your quality control of the graft and anastomosis?
Okay. Yes, extremely important question. The intraoperative quality control is with transit time flow measurements. So the Medistim device has an endoscopic flow probe available, which you bring in through the subcostal port, and that's a beautiful intraoperative tool. We do have the luxury of doing some of our cases in a fully equipped hybrid operating room, and we also do intraoperative on-table angiograms together with cardiology. That's not the majority, but it is possible as a confirmation. We don't do invasive angiography during the hospital stay or on follow-up, but we do CT angiograms after a year to see where we are with our IMA patencies.
Thanks. Gianluca, what is your strategy for checking the result of the anastomosis?
Since I started the TECAB program, I've been very fascinated by the use of ICG. So for those who are not familiar, using the robotic already XI platform, you have this button that allows you to go in a modality named fur-fly. And basically all of your screen become gray, and your anesthesiologist can introduce a little bit of this hydrosoluble contrast that become during this fur-fly mode gray on venous and then arterial phase. The contrast can be given to anyone. Creatinine is not an issue. Renal deficient, renal replacement therapy. The only contrast is, the only limitation is allergy to shellfish. So if you have allergy to shellfish, you should not give this contrast. Contrast is very simple, economical, cheap. Your local pharmacy prepare it. The anesthesiologist deliver that via the ICG, the right interjugular vein, and you see the contrast taking the venous phase. So all of the venous gets green, and then the arterial phase. If you use a bulldog, you can separate these phases, and you can see the backflow, as I showed before in my presentation, into your own lita. I'm doing this one on top of the TTFM. I started for fun, and now I like it, and it gives me even a second layer of proof that my anastomosis is good. And sometimes I must admit I'm a massive believer in TTFM and in medicine, but sometimes when I am totally endoscopic, the soft probe of the medicine doesn't never give me fantastic number of my flow. I don't know, maybe it's the CO2, maybe it's me, maybe it's the anastomosis. I'm not trying to hide. So I get good number. I get 30, I get 25, 30, 32, 33. Particularly when the stabilizer is still on, I never got excellent flow. And removing the stabilizer, it's a big deal for a TECAB. You have to make sure your anastomosis is perfect and is finally done, because you are off pump and because that stabilizer is stable side mounted. So you want to remove it just at the end. So to test and to have a second layer, I started to do this extra test. And I'm using the same element also for intracardial LED, or to test if I have some concern about my lita. You can check the flow of the lita. So it's becoming more useful and fun to try, and I'm developing a form of a skill that I hope to share soon in a paper and bring it out to the community to understand where we can do and what we can do with that.
And thanks. And Jan, what's your strategy in Hradec? How do you check your anastomosis or your lita?
You are muted.
We can't hear you. We can't hear you.
Sorry. Yes, some of us are using flow meter. That's all we have.
Sorry?
Yes, can you hear me now? In some patients, can you hear me?
Yeah.
Yes? Okay. So in some patients, if there are some uncertainty regarding patency, we are using flow meter.
Okay.
But not regularly in all patients, I have to say.
And talking about flow meters, one question on everybody: what is your opinion, pedico or skeletonized?
If I can just continue, we are using the same technique as we were taught by Stepan, so we are actually harvest so-called semi-pedicle. And so if you do so, that is not easy actually to use flow meter, as it is the case if mammary artery is skeletonized. It's much easier. So in a semi-pedicle, you can use flow meter, but you can actually clean the part of lima, of surrounding tissue, otherwise you are not able to get sufficient numbers. You know what I mean?
Yeah, very well. I agree. That's one of the things of why I skeletonize the mammary. But I think that all of this drama of skeletonized, non-skeletonized, I mean, it's you do again, cook your pasta in the way you like it. It's just fine. Like, I don't think that there is a way in which we should say or should recommend. I think I love skeleton eyes personally. Give me a lot of more opportunities, even in sternotomy, when I build Y graft, when I build eye graft, when I test my flow, I feel better. But I think whatever you want to do, you can do it.
I think, from my personal experience, I think skeletonized is mandatory for TECAB. As Jan said, we do this semi-skeletonized technique because I teach everyone the semi-skeletonized technique because I think it's safer regarding the pedicle itself. You are a little bit more far away from the IMA, so we are on the safer side. So my first TECAB I did with the semi-skeletonized, and I struggled a lot during the anastomosis. And then, since then, I switched to skeletonized in a TECAB patients. I still do the semi-skeletonized for MIDCAB. Okay, so let's move to the next question. Roll in isolated IMA to LAD, please. So it's probably a question for all of us, and I think we have already answered it, that it plays certain role, but probably the future is in more complex reconstructions using bilateral IMAs or expanding into the more hybrid field. The new centers, they sometimes struggle with the number of patients referred for the MIDCAB. They say, we want to start a robotic MIDCAB program, but we have only 8 or 10 MIDCABs referred to us from the cardiologists. And it's probably not the way to wait for more isolated LAD lesions. You have to expand to the hybrid field, to take some double vessel, triple vessel disease and work together with your cardiologists to establish a good hybrid program.
Do you believe, it's a question to everybody, especially for Johannes, do you believe that it's non-aortic grafting is the main, or Johannes, have you performed an aortic anastomosis?
No, we have not gone into that direction because we thought working in a high pressure system and putting vein grafts to the ascending aorta in the completely endoscopic setting is a bit of a stretch, at least. If bleeding occurs there, it's hard to manage. Concerning vein, first of all, if we do multi-vessel, the primary choice is in situ grafts, lima-rima. We can do Y grafts also. Constructing a Y graft anastomosis is very doable. We have done a handful of veins from the left axillary artery, so an axillocoronary bypass, if you wish. That works reasonably well, but I think the hybrid options are just less complex than that. So, yeah. But I'm aware of one surgeon, Jean-Luc Janssens in Brussels, who has decent experience with performing proximal anastomosis to the ascending aorta from the right, and then moving over to the left and doing a TECAB procedure with the vein grafts from the ascending aorta. That's what I know about it.
So it's doable, but it's for a limited number of highly skilled professionals.
Managing the aorta.
And Gianluca, there is also a question for you. Did you start with on-pump TECAB before jumping to off-pump TECAB, or how did you do that?
No, I just went directly to off-pump. I'm a big off-pump surgeon also in my sternotomy. I love anaortic bypass, 2 mammary arteries to revascularize the entire heart with extension of a radial artery or a venous vein. Lima LED, Rita Y-graft from the Lita to the OM, Rita extended radial for PDA and PLB, this type of revascularization. And my team was capable of performing TECAB off pump directly without any stepping on pump. I actually recently myself with my team went to visit Johannes. I was in his operating room 4 weeks ago, and I was taking notes because I believe that I want to learn more on pump TECAB. There will be cases in which I might want to go on bypass, bigger heart or complex cases, or patients that are very challenging or they don't tolerate ischemia very well. So I think it's good to have all of the techniques at your own hands, and I'm learning on pump after off pump. I feel more comfortable in off pump TECAB than on pump, but I want to have all of the skills. I don't think that I should. I'm not a religious guy. I don't believe in religious. I believe in skills. I want to have every skills that I can refine at my own fingertips, and then adapt to the patients and understand which patients can be suited for the best type of procedure. It's not on pump versus off pump. You are a surgeon and you decide what is the best procedure for that individual patient.
Okay, can we move the questions again? Simulation training for robotic IMA harvest. So what do you think? So you just recently started. Is there any good simulation for it, or you just jump directly?
I haven't found one. I just jumped directly. I think what helped me, as I did some open MIDCABs, I have extensive experience with that, knowing what the mammary artery looks from the thoracic side is helpful. And if you do it carefully, you would. I think that, however, cadaver labs and simulation training is a great thing to have if accessible. And I would urge everybody who has the opportunity to do that. In my case, it was not possible, but everybody who can do that, I think it's the safest way to start.
I think the simulators or the simulator exercises into in the system, they are under the development. They will develop some exercises, but I think the real wet lab training with a cadaver and big IMA harvest model is also very helpful. I think it's more difficult to insert the trocars in a proper position and manipulate them. It's more difficult than harvesting the IMA itself. Yeah. Okay, so we have a Wouter Oosterlinck from Leuven online. Welcome, Wouter. Let me introduce Wouter. Wouter is one of the leading robotic coronary surgeons in Europe. His main technique is robotically assisted MIDCAB using a lot of bilateral IMAs, and as we discussed the issue of pedicled against skeletonized IMA or IMAs, Wouter is a great proponent of skeletonized, and he uses a specific technique. I tried it several times. It doesn't work in my hands. I don't know how he does it with microbipolar on 8. And Wouter is joining us to give us a talk on the topic AI and robotics in cardiac surgery, current state and future direction. Please, Wouter.
Okay, just checking because I'm jumping out of the OR to the presentation. Can you hear me nicely?
Yes, we can.
Okay, fantastic. So I am happy to talk a bit on artificial intelligence in cardiothoracic surgery. There is so much to say on AI and specifically on this beautiful meeting. And I truly believe that robotics are probably the best way to integrate artificial intelligence and to reduce our learning curves in minimally invasive cardiothoracic surgery. Force feedback will be an additional helpful thing, but there's much to learn there yet. And we are just at the starting of this force feedback learning and using it in clinical practice. On one hand, the classical opinion is that AI is the way forward. On the other hand, it is assumed to be a bit dangerous. So of course, we need to know first, what is it? And it is a topic from computer science that we all are aware of now, that actually enables machines to perceive their environment, to learn and to interact with it, and to maximize the chances afterwards of achieving predefined goals. It is a pretty complex definition, but it shows us that it can help us in reasoning, planning of procedures, deep learning of procedures or outcome measurements. It can use artificial networks in this. And there are many examples of the use of AI, not only in medicine, but also in finance and industry. And the very classical example is ChatGPT, but also in the processing and integration of big data. In Europe, we have always been facing the last few years the MDR topic and the IPVR, which are very important, but there is also an opportunity. And the AI Act was actually the first established act on AI in Europe. And it predefines different risk levels of AI, of unacceptable risk or very high risk. It creates also a transparency on the topic, which is very useful. And it creates also a backbone for industry to interact with the clinical use of these kinds of topics and how we can proceed. So it is very useful. The law is applicable at the moment. And so it's a fascinating environment to move forward now. And first of all, I think in the preoperative planning, it is very useful, and the risk prediction. Also in imaging, intraoperative decision-making, postoperative care, training. Although there are also challenges in the transparency of data, the legal and accountability of what we get and obtain with AI, and the integration with the actual existing workflows that we are working on. Some of the things where AI is very applicable is in, for instance, the automated flow chart we created in the decision-making for coronary artery disease and single, double, and triple vessel disease, and where we can come to, according to the risk of the different syntax and neuro scores, we can achieve a choice or decision-making in an automatic way. And there AI can play an important role for the future, also by constant learning, because it can use the feedback loops that we create from outcome measurements, feed it back to the system, and make better decisions in the future afterwards. So that can be, first of all, already very useful. What do we see, for instance, in aneurysm detection? It can be very useful as well. We know that the vascular surgeons are using this, and this both for intracranial and intra-abdominal aneurysms, although it is a bit more complicated in the intra-abdominal settings than in intracranial settings. Intraoperative guidance, very exciting also and very useful. We see that is being used, for instance, for determining the dissection flaps and planes. And this is an example of one of our colleagues from Japan, Dr. Yuki, where you can see that the blue lines are actually showing us where the surgeon with his bipolar instruments, and to be honest, I learned my bipolar technique from the thoracic surgeons. And you can see how the blue lines are indicating the angel hair that we learn in our residency years, and where to continue for a clean and clear-cut dissection afterwards. Also, and specifically in robotics, we can see that we can create in the console an overlap or overlay situation where the important structures like a circumflex artery can be indicated as an overlay typlo being used in the console, which can be very useful for safer stitch placement and less chance of obstructing the circumflex artery, for instance, in ring annuloplasty. Also in the decision-making of the mitral valve morphometrics, we can do the measurements and we can easily predict afterwards the result of a repair that is planned up front and how the best repair can be achieved afterwards. This, of course, requires a lot of learning and a lot of input data first. And it will require input from chordae implantation, the annuloplasty itself, and the way of closuring the valve when triangular or quadrangular resections are taking place. We can learn from the surgeons that are performing the procedures robotically. We can also learn from the audio output that is being created. We can use the audio data also as capturing data for learning processes and also even for automatic data databases creation. So there are many opportunities there where computer science and AI can help us optimize our flows and the interaction with the robot. They are fantastic. One additional example is, for instance, that it is possible to measure blood loss through the blood pixel count through the robot. And these counts are actually quite predictable and quite correct in their estimates. And this is just a starting point on how we will predict our blood loss. Instead of counting compresses and the weight of the compresses, this is a future-proof technique that might be very interesting as well. A lot depends on which protocols and which formulas are being used to do the calculations. So the connection with engineers and computer science, they will need input from surgeons out of this. What are we focusing on from the EACTS, for instance, is the capturing of data in a semi-automatic fashion for the adult cardiac database. And there is now a very specific database for robotic parameters, which is huge, a huge database, and which will be extremely useful for our future-proof analysis and science that we want to perform. So I want to certainly stimulate and motivate everybody who is doing robotics at the moment in Europe and not in Europe, also in the US. If there is a possibility to participate in this, a very dedicated robotic database that is now available and accessible, it will be a fantastic way to share this data and to work on this together. Another example, for instance, is in the patient care perioperatively. We are using currently an app that the patients are using on their smartphone that helps in their pre-op preparation, that helps us to recover all the data like functional EQ5D data and assessment of patients. That also captures the patient satisfaction afterwards. And when they go home, we have some safety parameters that we monitor that we didn't monitor actually a few years ago, and where we now have the possibility to do a better follow-up in our patients when they leave the hospital soon after 2-3 days, and where we don't want this gap of lack of knowledge when those patients are no longer within our walls available here. Also, their AI is very useful, and it helps us to feedback because not every patient is the same. And so every patient deserves actually physiotherapy that is tailored on his own needs. And so one patient might be in a wheelchair and will not do many steps every day. Another patient is a marathon runner, and he will have higher expectations in moving afterwards. So we can really assess the patient at any moment, and with AI feedback exercises that are tailored to the patient and which they appreciate a lot because it feels to them that it's no longer a machine, but it's real life feedback that they offer, that they get, and it makes also the interaction with the physiotherapist afterwards much more useful and effective. Last topic to talk about is maybe also in training. I think AI will play also a crucial role in there, both in MIDCAB and TECAB preparation. We have fantastic models now available of 3D printed patients, where we can measure also our anastomosis, where we can feedback also the data of the quality of the anastomosis and the useful moves that are being made by the surgeon inside the model before we let them move towards any patient afterwards. So we can gather a lot of useful data and feedback the data afterwards to the participants to have a safe and quick learning. And same thing for mitral valve. There are fantastic mitral valve simulators now available, which are very complex, but on the other hand, easy accessible, and which gives a good feeling on how the situation is, where we can optimize the workflow, and again, through AI, feedback the workflow. And imagine even having a feedback system in your TAL Pro where the computer tells you when your stitch is suboptimally placed and where you can adjust your needle positioning according to the needs of the act that you need to do. So many opportunities there to make it very lifelike. Also, a white plastic model can become a lifelike model with an overlay situation afterwards. There are many opportunities. Here is just an example of the fluid dynamic analysis that we're doing in these anastomosis performance. Many opportunities there and very useful data to feed back to everybody who wants to learn robotics. So AI is certainly here to stay. Both for robotic, but also for other fields in cardiothoracic surgery, and many of us will benefit from it. We will have cross-fertilization across the different procedures that we do, and this will speed up diffusion and safety of innovation. MDR in Europe, it has been a hurdle, but now actually, together with the AI Act, is a very safe haven where we actually have a clear network and framework how to move forward. And these technical novelties will be very useful, in my opinion, in training and proctoring afterwards as well. Thank you.
Thanks for the excellent presentation. Will you stay with us for a few more minutes?
Yes, absolutely.
That is great. I have the first probably question for you. Around 7 months ago, in Science Robotics, the first case was published where a robot individually did a cholecystectomy, or the most part of cholecystectomy, without human help. Do you think the time that we put the trocars in the chest and then the robot harvests the memory are near?
I think we're certainly nearer, I think, to be honest, and we have to check with him, but I think Gianluca has been working on this kind of things before. So let's leave him the word afterwards, maybe if he's still there. And yes, I think times are getting nearer. On the other hand, we all know that surgery is not always the same, and you have to have the flexibility to interact. And yes, takedown of the lima is very standardized and not very complex. It is easy to learn. On the other hand, we all know that some patients have rib fractures, some patients have pectus. So the situation in place is still somewhere different. It's the same as self-driving cars. Does it work? Yes. Is it possible? Yes. But the situation in the field can have unexpected input, and there the system has not been fed enough. So we need much more input in these intelligent systems so that they can interact and they can learn what different situations bring and how the system must interact with these changing situations. So there we are not there yet. I think now we are in a very exciting timing where we can see this happening, where we can benefit already in the very basic acts that we are doing, but we have to use it now in an intelligent way. And no, it is probably not wise yet to let just the system take over. Let's use it wisely, feed back the system the data that it needs to become better. But I am convinced that much more will be possible in the future in an automated fashion.
So if we can compare it, it's like doing a transatlantic flight where the autopilot flights, but you have still two pilots who are there just in case anything happens.
Yeah, at the moment the system is not ready to do it, but indeed the surgeon still performs everything. But the fantastic feature now is that the surgeon can be much better prepared, that he has more tools than humanly possible to do the procedure in the most perfect way, and that you can afterwards do a follow-up also in a suprahuman fashion. So there is the added value at the moment. Of course, there will be science that drives us to self-driving systems, but there it is not ready yet.
But that might lead to a higher precision, higher standardization, and better results for surgery, which is what we have for our patients.
Absolutely.
And I think the new systems which are coming, they already have something integrated. and it's the tracking of the instrument and creating the curves and recommending how to improve. So I think this will change probably the surgery as a specialty or across the specialties, all kinds of surgery, because now you will have these data available and you can compare yourself to a benchmark or a average surgeon, and then one day you will have a list of surgeons who is the best, who is the worst. It's scary a little bit.
Well, I think if anyone wants to create lists, they would be already there. So who knows? But from what I hear, we are on the verge of a revolution that would completely change the way we treat patients surgically, and very importantly, increase the quality of the things we do, which I'm a big believer in cardiac surgery strength, especially cabbage over the known alternatives. So I welcome it, and I can also say to all listeners who have not started robotic programs, start and try to be a part of that revolution.
So what do you think will be the next real thing happening in this field? The first which will be introduced in your clinical practice from the AI in robotics?
I personally believe those would be warnings.
Warnings.
When you are performing something on a console, I think based on that machine learning, for example, harvesting the memory and not seeing a branch that you could get a warning, be careful, here is a big branch, you might want to clip it instead of burn it.
Or something like instrument angle, obstructing the view with the instrument, change the angle, put your wrist down, lift the tip of the instrument, things like this.
Or probably when you get very new to the phrenic nerve, you say, here, attention, phrenic nerve is there, and probably optically enhance the structures that are important.
Yeah, so the tracking the structures and giving the warnings to the surgeon.
And moving forward, I think connecting CT scans with imaging and feeding them in the system might later tell if you have a case where it's hard to find a lemma. I think the system might help you in locating your target and can show where is exactly the stenosis, so that you are for sure behind the stenosis. But I'm curious. We have here an expert.
What about, so that's one of the ideas, and before we ask Wouter, what about, for example, guiding you where to place your ports based on the CT scan and the stiffness of the shoulder, and then the robot scan the chest and just make points?
Yes, and I think that whole advantage would result in less conversions, less adverse events, less bleeding, and would make the results of a already highly standardized procedure with excellent result. MIDCAB is probably the best we can do as surgeons. It is our best grafts, the best patency, very low, and if we make it even lower, I think we have the chance to beat all other alternative treatments and probably get cardiac surgery on the growth path again. I truly believe that.
So what's your opinion, Wouter? What will be the next AI thing introduced in a routine clinical practice?
I fully agree, and I think these warnings are useful, although I don't want, sometimes I'm a bit upset with my car that there are too many warnings while I'm driving, but still, I think they're useful, and they saved probably my life already a few times, I must admit as well. So they are useful, and I see the biggest opportunity for me now also in data. Getting data out of the patients, getting the system knowing our patients better and better, getting all this data fed to a central European or world system where we can learn from it. So getting data out of the patients, training and helping to train others in the safest way possible, having automatic feedback, even when the proctor is no longer present, that there is still somebody telling, keep your hands down and don't keep the elbows up against the memory artery. These kind of feedback things can be useful. And I think that's low-hanging fruit. Having, for instance, things that I'm dreaming of is, why don't we have a full cath lab image being put on top of our beating heart when there is an intramural LED, for instance? These kind of possibilities will be useful when you're digging in the septum to find the LED again. Warnings that can be useful are indeed coming from the hemodynamics when you're fully in your focus of harvesting a memory, and the CO2 might be a bit higher, and you see that blood pressure drops and the anesthesiologist interacts too slow. You can have this in a more reliable fashion by a machine. So that are for me the very interesting opportunities directly to benefit from. Smoothness in movement. If we are proctoring something or someone, we see the changes taking place, and there is a learning path that is steep, short and steep. And I think it is very useful, the steps that are being taken to show the efficacy of movements in a simulator, and when are you ready to go on cadaver or on human procedures. So there I see the biggest win for me, data out of the procedures and getting the technique, which is now in hands of many already. But as you said, I mean, MIDCAB is a great procedure. It has a fantastic outcome. If we want to improve it, we need to go for the marginal gains. And that we need to prove with more data. So we need to put all the data together. We need to have everything standardized in the most safe fashion. And then we need to combine our strength and help each other out. And these are all the benefits that we are having in the robotic field.
Yeah, great.
That's great. Okay, so it's a very, I think, a very positive vision, and I believe we as surgeons should not be afraid of the new, not be afraid that we won't have anything to work because AI will take over. I think this is a big chance for us to treat better our patients, and everything we do it for the patients.
Definitely, and now it's the time to actually design what we need for the future. Design and talk to the companies and talk to the IT people, because you can imagine a lot of things that can help us during the procedure. Okay.
So probably one last question, Wouter. How do you see the penetration of robotics in the next years? I think it's a growing field, especially in Europe. We were a bit behind the United States. So what are your thoughts on that?
I think it will grow quite rapidly the next coming 3-4 years. It will get a very high dispersion now. The people that are being trained are very enthusiastic. They see the benefits. We don't have to underestimate the time that needs to be invested in it. I think we need truly dedicated people in robotics. It's not just something to do a few times a year. You really need to dedicate yourself and learn this as a new modus operandi. You really need to dedicate yourself to it. I see it's going even faster in the younger people, and the younger they get and the younger that they step in, the easier they pick it up and the faster they go. It is impressive. And so I'm very hopeful for the future. If we will need our cabbage, we will be in good hands.
Yeah, thanks. Perfect.
Well, I think that's a great way to sum up our
exactly Thank you for the talk. Thank you for your thoughts as well, and thank you for joining us. I would like to thank also the other speakers, Johannes, Gianluca, and Jan. I would like to thank Hristo for helping me to moderate this discussion. I think it was a fantastic discussion, almost 3 hours. Thanks also AMS and Surgeon to put this together, and we will hopefully do this again soon or next year. And I hope that you all enjoy it. Yeah. Thank you.
And from my side, thank you, Stepan, for taking the burden to put up such a great summit. We are looking forward for a second one.
Thank you. Bye.
All right. Thank you all. Thank you, Stepan, for leading this.
Yeah. Bye.